Good afternoon, everyone. Thank you for having me. So I'm going to jump in here. So we're going to talk about hospital at home, but I'm going to talk about really care at home as a complete platform. And for us, it's really about how do we drive scale and efficiency in building a program like this. And hospital at home can be a smaller program, and scale becomes important. But before I do that, I want to kind of share a little story with you, which is kind of interesting. About 6 or 7 months into us starting our hospital at home program, my mother actually ended up being one of our patients in the program, which was pretty nerve-wracking, I have to be honest. Despite the fact that she told everybody who came into her home that I invented hospital at home and that her son invented hospital at home, it was really interesting, her take on her experience. And I remember the day we transferred her home, the very next day I called her and I was like, so how did it go? What did you think? And I'm thinking about all the work that went into us getting her home and all the planning that we did for the 6-8 months before we launched our program. And I'm thinking, oh, it's gonna be that great transport team, or it's gonna be Dr. Ortega, who she's really gonna love, or it's gonna be the fact that all the DME got there and she didn't need to worry about any of those things. And the first thing she said to me was, the food was amazing. The food? I'm like, why'd you get the food? But there's really a really good, as I sat back and I was a little bit like, oh my gosh, that's what she noticed, the food. There's a really interesting kind of thought that comes out of that. It's that if we do our things right and we do care at home right, all our patients and our family members should really care about is how the food is, right? And they shouldn't have to feel how complex this is. They shouldn't have to feel the pain of it. They should just really be able to experience it and go through it and worry about getting better. So I'll just do a quick snapshot of who Virtua is, as well as some of our results in our program to date. And I'm gonna walk you through scaling through really what we planned and what actually happened as we went and implemented this and as we work through it today. And then I'll summarize some of those key lessons. Then I'm gonna talk to you about something that came out of our development of our hospital at home program, which is our care after discharge program, and some key overall lessons and what's next for us as an organization as we think of care at home as a larger portfolio. So Virtua Health, if you don't know us, we're a 5-hospital health system located outside of Philadelphia in southern New Jersey. We have over 280 locations, over 2,800 medical staff, 14,000 employees, and 40 ambulatory surgery centers. We started our program, our hospital at home program, in January of 2022. And we're similar to a lot of programs, very much dictated by the CMS waiver. We were approved for the waiver in September of 21, and actually launched our program in January of 22. We have 24/7 RN command center. We have daily virtual visits from our hospitalist team, twice daily RN visits. We have our continuous monitoring RPM kits through Current Health. And we do our visits through our Current Health tablet, as well as our patients can receive PTOT in the home. And we do support our program through our paramedics. We provide meals, diagnostics, really the full gamut. We really started the hard way too, as I hear other organizations and how they started doing care in the home. Now, we have home health and we have a paramedic program. We have some of the bases for it. And we've done some population health and longitudinal monitoring as well, but we really kind of went in head first. And it's funny, I was talking to Chris today and saying, if I knew today what I knew then, I don't know if we would have done it the way we did it, but I'm glad we did because we learned a whole lot of things from it. Today we've had, and I'll walk you through a little more detail around this, over 2,400 days avoided in the traditional hospital stay. And we are, like I said, doing full acute care in the home. Our average length of stay in the home is about 3.1 days. And it's proving to be over a day to a day and a half shorter length of stay than those patients that are similar DRGs in the hospitals. And we as an organization have already removed 20 inpatient beds from our future planning. We have 2 major capital projects that are happening today. We're building a tower in our Camden facility, as well as we have another expansion in our northernmost hospital, and we've removed 20 beds from that. We believe, and we understand that in our community, in our 3 major counties that we serve, somewhere in the neighborhood of 20 to 24% of care is gonna shift into the home. So we're really planning for that as we plan for our future. So as we dive into some of the detail for us as an organization in our hospital at home program, we've treated, and this is out of date the second we print it, we're about 800 total patients today. We treated about 319 patients in our first year, and that amounts to over 4,100 total patient days, with 2,400 of those in a home bed. I would say today 90% of our patients go through rebedding, meaning they do some amount of their stay in the hospital, whether it be a day or 2 days, and then transition into our program. Only about 10% come from the ED. And we'll talk about change management, and I think that's one of the key drivers for us as to why that hasn't taken off more. We have a 5.3-day average length of stay. That was actually down below 5 days. We were at about 4.7, 4.8. In 2023, we've made a decision to actually go after those longer length of stay patients, those patients that are stuck in our hospitals getting 14-day infusions, 21-day infusions. We're like, just give them to us. We can put them in our program. We have a tremendous net promoter score. We have about a 17% all-cause readmission rate, and our escalation rate's about 5.7%. So let's kind of talk about scaling through what we were planning to do and what actually happened. And we look at this in a multitude of ways, really across 5 main areas. And if there's one thing you take away from this, scaling isn't about pulling one lever. You're not gonna pull one lever and all of a sudden grow your volumes. It really is a cognizant effort around all of these different categories to say, I'm gonna tweak these things, and then I will begin to get to scale. And trust me, there's still work that we're doing to drive scale as well. So we're gonna be talking about the clinical model, the operating model, how are we driving engagement, what is the economic model? Like when we met with our CFO, how did we, and our executive team, how did we get this across the finish line to invest in this, as well as what our technical plan looked like and what it kind of looks like today. So from a clinical model perspective, we started, it's actually kind of funny. We planned on launching our program in April or May of 2022. And on New Year's Eve, our COO called me and said, how quickly can you get your program up and running? Because we were going through a pretty significant Omicron surge at the time. And I said, well, we're saying May, but we think we could maybe do it in March. And he goes, how's January? And I said, January? You mean like this January? And he's like, yeah, January. So, and I'm like, well, how about February? He goes, how about January? So we actually launched the second week in January. And it was the best thing we ever did, because you'll see, if you haven't started a program, the best thing you can do is start. You don't want to get stuck in analysis paralysis and never start, because you can never plan for absolutely everything that's going to happen. You just have to be able to react to it and have the team that's going to evolve as you work through it. So we started day one focusing just on COVID. We're going to do remdesivir in home. We're going to try to get some COVID patients out. We defined a care plan, and we created what we thought was this amazing screening tool out of Epic, our EMR system. And as we got started, we realized, we started in a 400-bed hospital. We know about 30% of our patients are Medicare patients, and we ran our screening tool on day 2, and 9 patients showed up. The screening tool has to always be looked at and monitored, and we really went to a more human-mediated screening process. At that point, we're kind of still there at this point. We quickly expanded, probably in the first 3 or 4 days, the diagnoses that we're treating, and that's opening up that funnel and looking at how you can treat those patients, and really just started to tick away at each of the diagnoses and how can we provide a safe environment for them in the home. We expanded the screening criteria, and we rapidly expanded our different care models, and I'll talk a little bit about some of the ways we did that. So let's talk about the operating model. So we focused on inpatient rebedding, as I talked about, and we do take patients out of our ED, but the majority are out of our rebedding process. One thing that was really key for us too in our planning is we insisted to our executive team that we invested in dedicated staff for this. And trust me, that's pretty painful to do when you're sitting there with either one person in your program or two people in your program. But I'll talk to you about how we looked at that from an economic perspective. We also incorporated a medical director, and Raul, our medical director, is actually here with me today, and a dedicated physician lead for this, and that's crucial as well. We made insourcing and outsourcing decisions based on what we knew that specific day. And one of the keys for us is giving our operational team the levity and the ability to make decisions for how they think it's going to work, but that 6 months from now, they can change their mind. So we tried to, any contracting we needed to do, any sort of decisions we needed to make, we knew going in, these are short-term decisions because this is what we think it is right now, and it may change, and it changed as we continued to grow our volumes. So actually, as I said, that phone call was probably the best thing that ever happened to us. We started to learn day one. We got our first patient on day one, and it was a week before we got our second patient. That was the most painful week, probably of my career. We make quick decisions. Choosing your operational team is so key in this building any sort of care at home strategy. As much as people try to tell you there's no roadmap, this is going to be unique to you as a system, your community, what your physicians are comfortable with doing, what your executive team is comfortable doing, what the competition looks like in your community. So you have to have a team that's going to be able to make quick decisions, move on the fly, and have to have the stomach to be able to do that and manage that change management with the team. We quickly, in our first year, expanded across all 5 of our divisions to start to try to drive some scale, and expanded into our ED admit to home workflows within the first 9 months. And then we just this year insourced our DMEs. We went with an outsourced company to both provide and deliver our DMEs. That started to create confusion in the home. It affected our experience, and it was really expensive. So we actually insourced that and began to do it ourselves. So let's talk about the engagement model. We created these playbooks, which is kind of funny. This is what we thought it was going to look like and feel like, and they're continually evolving. And we went out there and talked to our clinical teams. It's funny. I remember Raul and I were talking about this today at lunch, and we had been planning and researching and saying we're going to do hospital at home, and we had this 2.5-hour meeting planned with the whole clinical team at the first hospital we're going to be in, and we're going to work through care pathways, and we had the whole 2.5 hours planned, and it ended up being a 2.5-hour change management session. They laughed, they cried, they yelled, and I remember one of our physicians said to us, he said, how are we going to get a bed to their home? I can't even get a commode down to their room in 3 hours. How do you expect us to get a bed in their home? And we turned to them and said, well, why do they need a bed? But that's where we were as a health system at the moment. And that was really a telling moment for us as to how much change management we really had to do. We hypothesized that patients would be more engaged with their care. We also really, we felt like this could potentially be a good offering for our physicians, remembering we're in COVID, burnout was huge, it's still huge today, and we were losing clinicians left and right. So change management is constant. I joke around that it's kind of like whack-a-mole. Just when you think somebody's in, about 3 months later, they're out. And one of our specialties, it's funny, is infectious disease. We do a lot of, cellulitis, UTIs, things like that. And it seems like we're all on the same page, and 3 months later, they don't want to send anybody into hospital at home. It's really interesting to watch and happen. And one of the things happened that, we were in a really great place with infectious disease at the end of last year, and then around January, February, they kind of came at us again. And I realized they were looking at their numbers from the year before. And when they go into our program, the patients are managed by the most part by the hospitalists. So we see a reduction in unnecessary tests, 30% reduction in consultations, with all the amazing results we've seen. So we were affecting their bottom line, ultimately, as they look at those consults. And we've been working with them and engaging on how they engage in our platforms and things like that. Our physicians and nurses, the engagement is through the roof, and we've really, those that are working in the program, and we go back to our physicians and show our results. Our hospitalists see this as a new mode of care. And you've probably heard this from other presentations, that they just see the patients differently. They can see, I'll never forget when Dr. Ortega, our lead physician, was talking on one of our daily rounds, and he's saying, you know what, I'm starting to see what led to this patient coming in the hospital. I could never see that before, because I'm sitting at their kitchen table, I'm seeing their family dynamics. I may be virtual, but we're having coffee together and they're talking to me in a different way. And now I understand why they came in and what can we do to keep them from coming back. And that creates for us a more holistic view and led us to some of the services, which I'll talk about in a moment as well. And then just as we talk to our team all the time about this, all of our leadership team, change management never stops, ever. We're always talking about it, whether you run into somebody in the cafeteria or you're on the elevator or you're in a meeting with somebody, we never stop talking about it. So let's talk about the economic model, because this is really interesting. People ask me this all the time. How did you go to your executive team and how did you get the funding for this? Because this is not inexpensive to do. If you really want to start a program and you don't really have the foundation like a command center or some of the technology, this could be expensive. And we're with our finance team, and the way the waiver works is that, as you all know, the revenue follows the license. So we have 4 Medicare licenses in our organization, because we're hospitals that have all come together. And they're like, you can't take any of the revenue. It has to go to the hospitals. And actually, that ended up being great from a change management perspective. I wasn't fighting presidents and COOs for revenue. So that ended up being fine, but then I'm just a cost center, and I'm just an expense organization. So we approached it with our executive team and our CFO like, this is an innovation model, and we need you to just invest in us, and we need this amount of money to do this in year 1. And we'll come back with our results. And if we prove ourselves, then we believe we can take this foundational service and build multiple other things that will have a great impact on our organization. And we got that first commitment for that funding. And that was such a relief, because we weren't sitting in a P&L situation where they were saying, well, you only had 319 patients. Even if you counted revenue, what does that really look like? It gave us the freedom to be creative and understand that we were going to spend this money, and it was what it was, but there were going to be benefits. We're betting on this innovation model, and there's going to be benefits to the organization that we may not be able to see today, but that we're going to take and apply across the organization, and that has held true for us. So we focused on Medicare fee-for-service and Medicare Advantage. We also pulled our employee population in and our employee health plan in to try to start to grow volumes. And the pay parity model really helped us with some of that change management from an executive standpoint as well. So that was year one. Year two in 2023 has really been about finding efficiencies and trying to cut costs. Insourcing the DMEs for us was a huge savings, as well as a huge experience change for us. We began treating our employees and their dependents. And we also worked with a local legislator to write a hospital at home bill in the state of New Jersey. And we wrote that bill to mandate that commercial insurers in the state of New Jersey would have to cover hospital at home. And also that we would be able to treat Medicaid patients. So it's funny, we talk about and we heard about, health equity and all these things, but in the state of New Jersey, we couldn't treat Medicaid patients. So that was an avenue for us to talk to our legislators and say, if we want health equity and we really want this to be effective across our community as a whole, we need Medicaid to be in this as well. And by the way, the commercial payers aren't covering this. And as of September, the end of September of this year, our governor actually signed that bill. And we went and testified in front of the state assembly and Congress and got that bill passed in the state of New Jersey. We may be one of the only states who have passed that extensive of a bill. And I hope all of you go back to your states and talk to your legislative teams about doing something similar. And that's opening up the door to have deeper conversations with our commercial payers with this new state legislation. So the technical plan, as we look at it, we really knew a lot of what we were going to be able to do, because we were starting so fast, was going to be human mediated to really do what we call our minimal viable product. Like, what is the least amount or the smallest product we could produce. And now we've been slowly engaging more technology. We had an existing remote patient monitoring vendor that we use for longitudinal monitoring. We were using that. Within the first 2 weeks, we were no longer able to use that system. It just wasn't working for us. And we went on a vendor search, which is how we met Current Health and began using them in our program. And something that was kind of not really an accident, but a really cool thing that ended up happening out of COVID. We ran our vaccination centers in our community. In one of our local malls, we popped up testing centers and all of these things. And our IT team didn't want to have to go into each of these different areas and create the Virtua network and wire these buildings that we were only going to use for a short period of time. So they created, basically they're like little briefcases that we bring into, that they use to essentially replicate the Virtua network in these community settings. And they have 2 wireless cards in it, picks up the strongest cell signal in that community, wherever it is, and broadcasts the Virtua network. We now take those and put that in every patient's home that we treat for hospital at home. And that enables us to have the Virtua network within their home. So all of our nurses, all of our clinicians, they all can open their laptops, and it's like they're sitting on one of the floors in one of our divisions. As well as it started to open up the door for us. It start to integrate technology into what we're doing and look at even our bricks and mortar technology in a different way and how we treat our patients. So, next slide. All right, from an actual, as I said, we had to find a new continuous monitoring and new remote patient monitoring vendor, which has worked out great for us. We began utilizing and looking at interoperability with the Wi-Fi network and our Virtua network in the home. And IV pumps, we adapted to programmable IV pumps. One of the challenges we had were getting staff out to the home if somebody was on Q8 meds, and can we change it to Q12, and what do we do? So we actually found a vendor that does programmable pumps. But even more exciting than that is because we do the network in the home, we're actually able to take the IV pumps from the hospital, the same ones, and use them in the home. That way, from a safety perspective, when the drug library is updated across the system or any changes are done there, it actually automatically updates our hospital at home IV pumps We can do scanning with those IV pumps, and all the safety features we have in the bricks and mortar are in place for us in the home. And that was very important for us. So overall, from starting a hospital at home, what are some of the key lessons to both scale as well as just development? First of all, executive sponsorship. It has to go all the way up to the CEO and the C-suite, and they have to buy in that we're going to spend this money on a program like this. There has to be clinical viability. I think one of the secrets to our success is having embedded physicians who are hospitalists. Raul is not just our medical director for hospital at home, he's the medical director for the hospitalists as well. So I think having him and a lead physician from day one was key for us. Constant communication and change management, and I can't say this enough, but fluid design. We look different every day, and a month will go by and we'll talk about, wow, remember when we were doing this way and now it looks like this? We are not even the same as we were when we started this year, let alone when we started the program. It has to be fluid and you have to change and evolve. So that brings me to our care after discharge program, which, this is gonna sound really cheesy, but I think it's actually, I joke about it as the chocolate that fell in the peanut butter for us. Like, this is something that came out of us trying to think about how do we get to scale, how do we have a greater impact on our system, and how do we create something that really helps our patients in a different way. We were also talking to other organizations who were doing hospital at home programs, but maybe not doing acute hospital at home, and they were doing like a home health with extra support built in, or longitudinal monitoring with extra support built in. But what do we need and what do our patients need? And it's funny, it actually, not to keep talking about my mom, but it actually also roots out of something I heard my mom say. She was like, when I was in the hospital at home program, you brought all these great resources to me, and I had all this attention and I felt watched and people were taking care of me. And then I got discharged and it was gone. And I was so scared. I didn't know what to do, and it made me nervous. So we started what we call care after discharge, and we started it in April of this year, and we built it out of the hospital at home chassis and foundation. So we're using the same physicians. We're using our hospitalists that are our hospital at home physicians. We're using our nurses. We're integrating our paramedics. And we're using the same RPM kits. We're doing continuous monitoring. So essentially, this is a virtual transitional care unit. It's a 24 to 72 hour stay. And the beauty of this is it's payer agnostic. We're not just Medicare, Medicare Advantage, it's all payers. Our patients get discharged, and our goal was to reduce the risk of readmissions, reduce length of stay. We have an excess stay and length of stay problem in our organization, so can we help support that? We hear all the time the physicians say, I just want to watch them for one more day. Well, if they had a solution where they knew they were being watched and we could watch them for 24 hours, we could say, we'll watch them for you. We'll take your patients, let's discharge them, we'll watch them for you. Improve patient satisfaction and preparedness to go out into that outpatient world, ambulatory world, and provide physicians with the peace of mind that their patients are transitioning safely. So every patient in our program for care after discharge, they get a virtual visit from one of our hospitals within 24 hours, in the first 24 hours. We do an in-home med reconciliation with a virtual pharmacist, and I can't tell you how many medication challenges. You all know this, we hear it all the time, but it doesn't feel real until you see it in real time. We do 24 hours continuous monitoring on the first day. Do I think that's, clinically, like we have to do that for every patient? We don't, but it really helps, both with the change management for our physicians, but also for our patients. We have virtual nurses check in. They have access to our 24/7 command center if they have any questions. And we've integrated our paramedics as hospital at home techs. They go home, they go into the home, they set up the RPM kits, they do a set of vitals, and they facilitate the in-home med reconciliation. But then we also look at their appointments. I know it sounds like something really little, but they'll say in the hospital, I have a primary care appointment or I have a specialist appointment coming up. But once we see them in the home and our physicians see them in the home and they find out that they're not going to see their pulmonologist for 14 days, we go in and say, no, they might need to be seen like tomorrow or the next day, and we work behind the scenes because it's all one system to get them in the next day. And that's one of the keys for us. So what kind of results have we seen? And this is out of date. We've seen over 700 patients through our care after discharge program. So now think about scale. Through the same chassis that we built our hospital at home program, we saw 319 patients last year. We're going to see about 550 hospital at home patients in 2023. And we'll probably be between 800, 900, maybe even 1,000 care after discharge. Now we're getting to 1,500 patients through that same expense and that same foundation. But what's even more impactful, and we're alive in all 5 of our hospitals, is that we've seen a huge reduction in length of stay. Our physicians are telling us this is what they've been looking for. They feel like their patients are safe. It's anywhere between a day to a day and a half reduced length of stay for every single one of those patients. You can kind of see where we are across the DRGs. And that's huge for us as an organization. I think we're just scratching the surface on that and the capabilities. I think what's even more important, which isn't on this slide, out of 700 patients, we've had 7 30-day readmissions. That's a 1% readmission rate. And that's just by watching them for 24 to 72 hours when they get home. And I will tell you, probably 50% of those readmissions we sent back. And they skipped the ED and we direct admitted them because they just weren't ready for whatever reason. So our care at home journey really lessens, and this is overall just care at home. You've heard me say these things, but starting is the hardest part. Just start. You have to do something because you're going to learn so much from it. I think another aha is that teams are working together in this environment in uncharted ways. Somebody's in person, somebody's virtual, somebody's in a command center, somebody might be in the hospital, and they're all working together in uncharted ways. Flexibility is key to development. Test, learn, and adapt quickly. Don't sit on mistakes. Don't avoid change. Change as quickly as you can. Grow intentionally, but be smart about it. Scale is the thing that will expose broken processes like nothing else. I talk about it to my team like a pipe that has cracks in it. If you only put half the water in it, you don't really see all the cracks, but if you fill the pipe all the way, you see all the water gushing out. That's what happens as you grow your volumes if you have broken processes. And ultimately, what we've come to terms with is workforce availability. This is a unique skill set. Not everybody can transmit empathy across a video screen. Not everybody wants to go into the home. Not everybody wants to work in that hybrid environment. And we may have to train this workforce as we grow and develop it across our community. We don't know that it's necessarily 100% out there for us to just grab. So what's next for us as organization? Because this really, you can see, care after discharge, we're now starting to drive integration and pulling these services together and thinking about things in a different way. I think one of the unique things for me was how going into hospital at home has also made us, and doing care virtually and some of the things we're providing in the home has made us think about our bricks and mortar differently and how we provide care there. So what's next for us, and I stole this shamelessly from SG2, but for us it really spans across the continuum as we think about the foundation with home health, virtual visits, remote patient monitoring, but it's on-demand care at home. We're now looking at how do we provide labs. I can't tell you how many patients after 24 hours don't have that crucial med. They either ordered it through a mail house or their daughter or son never picked it up. How do we deliver medications right to the home? Urgent care in the home, primary care in the home, chronic care, and some of these we already have in flight already today. Dialysis, infusion, acute care in the home. We have to be able to get to observation in the home. That's not part of the CMS waiver, but we are going to be talking to our commercial payers about how we get into that space. And that kind of walks you into this continuing care in the home. So for us, as we look at care in the home, it's truly about scale. But I have to say, I think as we think about disruptors and different organizations coming into our community, we look at it slightly different. And the way we look at it as an organization is the group that's going to win at this is certainly scale from a cost perspective, efficiency perspective. But the group that can do this in an integrated way that feels absolutely seamless for the patient as well as clinicians providing the care, that's going to be the organization in our communities that wins at this, in this care at home space. And we're doing everything we can to be that first. So with that, I'll open it up to any questions. I think right there. Go ahead. No, go ahead. And then
thanks. That was great. I love hearing about your change management approach. And I'm wondering if you could enlighten us as to, because you have so many different teams and people looking at vitals, and how did you sort of navigate, and as a new team looks at a vital that's remote, like how did you sort of navigate and survive through those rough waters?
I think one of the tricks is our leadership team. I think, we insisted not just on dedicated physicians, but a few people that as leaders. Kristen, our AVP of clinical operations, talked the other day in one of the sessions, and they were under the hood with the teams doing it with them. So that, I think, really started to facilitate that constant communication. I think the other thing that was really important for us is, this really is a lot about trust, right? Like if you're a nurse going into the home to do acute care, even though you have the command center, you're alone, right? You're by yourself, and the physician might be virtual, the command center is virtual. So they had to learn to trust each other, and for me, that started with the leadership team. I think the other thing we did was we took their comments, recommendations extremely seriously, so that they could see we were driving change based off of what they were seeing, and we were doing it quick and fast, and then that fostered that trust, not just in our leadership team, but in each other. And that's really what I would say. That's a long-winded answer, but someone here had a question real quick. Oh, okay, go ahead.
Were there any disease states that were easier to stand up quickly? I know you said you covered like certain diseases and had to scale to kind of cover all of those, so were any easier than others?
I would say, a lot.
Can you repeat the question?
Yeah,
please?
so she asked if there were any disease states that were easier to start with. That's a good question. I think, a large majority of what we treat, I would say upwards of 50% are respiratory. So we do a lot of COPD, community-acquired pneumonia, things like that. We've seen some of the biggest resistance, I mentioned it in ID, because they want to set their eyes. They feel like they have to see the wound in person, if it's a cellulitis or if they have things like that. So we're trying to address those concerns by making changes, and is there technology we can do? We're looking at technology that scans the wound, measures it, things like that might make them feel safer. But I don't know, like Raul, am I pretty? Okay. All right, there was a question back here.
For your care at home post-discharge, do you have a payment model for it as a visiting nurse visit, or no, you buried it under the innovation funds, at least for this year?
So, no, we do get paid for it. We actually put up a specialty practice that is staffed by hospitalists. So I know that sounds crazy. But we did that, and we bill for the physician visit, and then we facilitate the transition to like our transitional care team as well. That does the transitional care codes, and then they can get the RPM repayment, things like that. It's not a lot of money. So a lot of the financial justification for care after discharge is our reduced readmission rate and our pretty dramatic reduction in length of stay. So as we look at 2024, we're projecting our care after discharge program to treat somewhere in the neighborhood of 2,500 to 3,000 patients. And that amounts to about 8,000 to 9,000 day reduction in our facilities. That in itself gets a lot of attention in our organization.
Congratulations on the hospital at home bill. That is phenomenal.
Thank you.
I was wondering, does it mandate that the payers cover the full DRG?
So that was something we couldn't keep in. We had pay parity in there to start, and our assemblyman, who happens to be, Herb Conaway actually happens to be a physician as well, was pretty adamant. But we wouldn't have gotten a signature with pay parity, for sure. So we know we're entering that battle right now because they have to begin covering it at the end of January. We gave them a 4-month grace period to get started. And honestly, before the bill, a payer came to us and they wanted a 30% reduction. We're not gonna do that. We just won't do it for their population. But we feel like with the results we have, we also have a pretty significant, we actually just published a paper on our reduction in skilled nursing facility utilization, and that gets the payers' ears. Yes.
So, I mean, congratulations. This is great. And I mean, I'm really inspired about that care at home program. But I think my biggest question is around the logistics. So for like really in relation to like the RPM and the kits,
Yeah.
so do all patients get a current health kit for the CAD program?
Yes, all patients get a current health kit for the care after discharge program. They do.
And they have a length of stay of like, I think when
24 to 72 hours.
Okay, so short.
So in our organization, we have a bit of a disparate longitudinal program. We're in the process of bringing that together into one program. And many of those patients will stay. We won't have to transition to another kit, so there'll be a lot of benefit for us as they stay on one kit. Logistics is, nobody has the answer for that yet. We're still learning. I don't know if I can tell you this is exactly how to do it. I could tell you, 5 patients is different than 10. Now, between the two programs, we have an average daily census of somewhere in the neighborhood of about 20 patients in our program across at least four different counties. Logistics is, the one who figures that out is gonna be, that one's gonna be the key.
Yeah, I've been trying. Like, we've really had a lot of success with like our Geek Squad model for like our guys here at home and our complex case management. I think for hospital at home, like we have our nurses bring them out. But I was just thinking like that's a pretty large patient census to just keep having kids like go back.
And we're
with.
really trying to push to top of licensure. We have our nurses doing things that they wouldn't do in bricks and mortar, which is okay. But when we start to think about expenses, so one of the keys for us is actually New Jersey was behind on the utilization of paramedics in the community. They don't do it like Massachusetts. They were only allowed to treat within their vehicles and things like that. We actually, just prior to the hospital at home bill, had legislation passed that models other states for paramedics. So we created a position called a hospital at home tech position, which is in anticipation of that bill being enacted and signed, which it has been, and goes into place next year. But we have paramedics that now go into the home, do the DME, do the RPM setup, do the vitals, things like that. Like, we're kind of prepping and trying to evolve our model from a logistics perspective. But I think the other big piece that's not out there is really the scheduling, the predicting, the organizing, the asset tracking, all of those pieces from a technology perspective.
Thank you.
All right. Thank you.